Good morning. I'm Dr. Luke Evnen. I'm chairman of the board of directors here at the Scleroderma Research Foundation. Thanks for logging in today for another webinar in our series. It's a pleasure to be with you today, and really an honor for me to introduce our special guest who joins us from Northwestern University in Illinois. This is actually our 10th live webinar, and I'd like to remind everyone that each of our sessions can be viewed on our website, which is sclerodermaresearch.org, all one word. In addition to the webinar series, please be sure to browse our ever-expanding library of research and patient-related news, all available free of charge. And of course, we do welcome your feedback, and anything that you suggest we'll incorporate into the program to try to optimize the use of the materials for the scleroderma community. And of course, we also appreciate your generosity. The Scleroderma Research Foundation depends on generous support to speed the progress toward a cure, so please do consider making a donation after our time together today. I would like to thank Gilead Sciences, MedImmune, and Novartis, who've all made grants to make the webinar that we're presenting today possible. And today's session will focus on scleroderma as a treatable multi-system disease. In the next 40 minutes, we'll learn more about the effects scleroderma has on the individual organ systems and the therapeutic options that are available today. And we'll also wrap up with about a 15-minute Q&A session after Dr. Hinchcliff has completed her presentation. Due to the number of participants joining us today, the phone lines have all been muted, so please, if you have a question, use the chat box in the conference window. I'll try to organize the questions that come up during the presentation to streamline the process at the end and hopefully get an opportunity to address as many of the questions that come up as possible. I should remind you that our webinars are for general information only, and no information provided is to be considered personalized medical advice. As we all know, scleroderma affects everyone differently, and no two cases are exactly alike. So with some of those caveats, let me switch gears. It's great to have all of you with us, and it's my pleasure to introduce Dr. Monique Hinchcliff. Dr. Hinchcliff is the Director of Translational Research at the Northwestern Scleroderma program, and she's Assistant Professor of Medicine in the Division of Rheumatology. She earned her medical degree at the Chicago Medical School and completed her residency in internal medicine at Norwalk Hospital in Connecticut, a Yale University School of Medicine affiliate. She also completed a fellowship in rheumatology at Northwestern University, the Feinberg School of Medicine. Dr. Hinchcliff divides her time between caring for patients at the Northwestern Scleroderma program and conducting clinical and translational research. She has won several research awards, including a recent grant from the National Institutes of Health for her work on the development of biomarkers to classify various types of scleroderma and evaluate response to therapy, a project for which she received seed funding from the Scleroderma Research Foundation. It's my pleasure to introduce her today as she prevents systemic sclerosis, a treatable multi-system disease. Please. Dr. Hinchcliff?
Yes. Can you hear me?
Yes, I can. Thank you.
Okay. So thank you, Luke, for that nice introduction, and welcome to all the people who have logged on. I see the list growing before my eyes, so it's wonderful to have you all with us today. And thank you to the Scleroderma Research Foundation for inviting me to be a part of this webinar. It's the first webinar I've ever done, so let me know if I'm speaking too quickly or if there's anything I can do to make it more educational for all of you. So I was asked to speak about systemic sclerosis as being a treatable multi-system disease. So that it's obviously a multi-system disease, so there's many organ systems affected. So we won't have time to discuss all of them, but we'll discuss the major ones. And of course, we can I can answer questions at the end if there's something that I don't address. So just a brief disclaimer. I am showing a lot of pictures today that I've either pulled off from the web from non-proprietary sources, or I've requested special permission from patients to show the images. and I can certainly provide references upon request. So let's get started. So this is just an overview of my talk. First we'll talk about the way that systemic sclerosis or scleroderma is named, which can be confusing to a lot of patients I have found. So there's two major types, limited and diffuse, and there's a term called CREST, which has been in the past used to refer to some of the symptoms that are associated with the limited form of the disease. So we'll talk about that, and then we'll talk about some of the treatments for some of the organ-specific complications. So here's a 19-year-old woman who's near and dear to my heart. She developed scleroderma when she was a senior in high school, and when I saw her, this on the left was when she was trying to make a fist. And right here, can you see the pointer? And then on the right here, she was trying to fully extend her fingers.
I'm not sure the pointer is showing through.
Let me see. They told me how to do this. Let me see. Can you? Oh, that's sorry, the wrong tool. Here we go. Here's the pointer. So here's
that's it. You got it. Thank you.
That's it. Okay. So here's the patient trying to make a fist, and then here's when I asked her to try to fully extend her fingers. So I think that gives you a sense of how devastating this disease was for her. So systemic sclerosis is it's defined as a connective tissue disease, and we don't really know what causes it. We know that there's an environmental trigger in a genetically susceptible individual. So what does that mean? We know that identical twins who have the same exact DNA background, the chance of both of those twins getting scleroderma is less than 5%, 5 to 10% it's been estimated in twin studies. So that tells us that even when two individuals have the exact DNA, only about 5 to 10% of the time will both twins develop the disease. So that tells us that it's more than just, the genetic background of the individual, and that there must be something in the environment that the different twins are exposed to that triggers the disease in one individual and not in the other. So that's the information. That's the evidence behind that statement. As I mentioned, it's a multi-system disease characterized clinically by skin fibrosis. So that's what we look for in the clinic when we're making the diagnosis, is evidence of fibrosis, thickening of the skin. We also look for internal organ fibrosis in the heart, kidneys, lungs, and the GI tract. Interestingly, systemic sclerosis does not affect the liver and also does not affect the brain, unlike other connective tissue diseases like lupus, where the brain can be commonly affected. There's vascular problems that are definitely associated with the disease. Evidence for this is the Raynaud phenomena and also pulmonary arterial hypertension. So we'll talk more about that. And then there's autoantibody production. So these are proteins that are present in the blood of patients with scleroderma that are not present in most cases in healthy patients or in healthy individuals, and those are referred to as anti-centromere and anti-topoisomerase. And I know those are confusing terms, but I think it's important for patients to know their autoantibody status. And you should ask your doctor, do I have an anti-centromere antibody? Do I have an anti-topoisomerase antibody? Because your risk for developing certain internal organ complications from the disease is affected by the presence of these autoantibodies. So if you don't know your autoantibody status, you should definitely have a conversation with your doctor about that. So sorry, something just popped up on my screen. There's two clinically identified subsets, as I mentioned. So there's the limited cutaneous form, and in that form of the disease, patients will notice tight skin, perhaps on their fingers and their hands, and involving the arms below the elbows and the legs below the knees. So it doesn't go above the elbows or above the knees, and it can involve the face. Whereas the diffuse cutaneous form, it may involve the fingers and the hands, but it will also involve the skin above the elbows in some cases and above the knees in some cases. And truncal involvement is diagnostic of the diffuse cutaneous form. So if you're a patient and you just have some skin thickening on your hands and on your arms, but it's not involving your trunk, chances are you have the limited cutaneous form. of systemic sclerosis. And if you notice that there's tight skin or itchy skin or very pigmented tanned skin on your chest, then that's evidence that you may be developing the diffuse form of the disease. And it's important to note that both subsets can involve the face, so that does not help differentiate between the two subsets. So there's these two clinically defined subsets, and they differ in the types of autoantibodies. These are proteins that are present in the blood. They differ in the pattern of lung involvement, so that limited patients will more likely have a vascular or a blood vessel lung disease, whereas the diffuse patients will more likely have more fibrosis, more scar tissue that's affecting their lungs. And so we think, just this is a very simplistic way of thinking of it, but that the limited patients have more vascular changes, whereas the diffuse cutaneous patients have more fibrosis. That's more of the problem for them, although there's certainly overlap between the two types. So the limited form, we'll talk about that first. So it's more of a vascular disease, and most of you probably experience Raynaud's on a daily or weekly basis. So you're familiar with the skin color changes, the blue, the white, and the red. Some of you may have developed these vascular ulcers. And it's important to note that the vascular ulcers occur on the fleshy portion of the finger. They're not on the knuckles. Those are traumatic ulcers. When the ulcers form on the knuckles, those are more just from banging your knuckle and your skin's tight and you induce trauma. So the vascular ulcers occur on the fleshy part of the finger. I show this picture because if you have a vascular ulcer, you should not consent to have a portion of your fingertip removed. This patient probably was treated in the 80s or the 90s and has had obviously a lot of surgical resections of distal parts of the finger. I've never referred a patient for this. I've never needed to. Fortunately, the body, when it develops a digital ulcer, if there is tissue loss and some of the tissue of the fingertip dies back, the body will do that on its own. And so we don't refer patients to have their fingertips resected. The only case where I think that's really warranted is when there's uncontrollable pain and we just can't treat the pain, or if there's a severe infection that we're unable to treat. So I think this warrants a second opinion. If you develop an ulcer like this and your doctor is suggesting to have surgery, I think it definitely warrants careful consideration. This is a picture of an echocardiogram. And that's part of standard clinical care to get an echocardiogram. And you'll see here, this is the right side of the heart. So the heart's upside down. That's just the way that the probe shows the heart. But so this is the right side of the heart. This is the bottom of the heart. This is the top of the heart. And this is the right side and the left side. And here's the septum in the middle dividing the two sides of the heart. And hopefully you can appreciate that this right side of the heart is very, very big. It's almost the same size as the left heart, if not the same size, and that's very abnormal. So this is a patient who has pulmonary arterial hypertension, again, one of the vascular complications of the disease, and the right side of the heart has had to enlarge in order to pump blood through the very diseased vasculature, the diseased blood vessels in the lungs. And here's a patient with telangiectasias, and those are abnormal blood vessels, and that's further evidence that there's vascular disease underlying the limited form of systemic sclerosis. So CREST, again, it's not a term that we generally use anymore, and the reason for that is that nobody really knew how many criteria you had to fulfill in order to have CREST. So patients would be very confused, as would doctors, trying to determine whether the patient had CREST or not, because there was no clear definition of how many of these criteria you had to meet. So again, the C stands for Calcinosis Cutis, the R stands for Raynaud phenomena, the E stands for esophageal disorders, and the S is Sclerodactyly, and the T is telangiectasias, and we'll talk about these one by one. So Calcinosis Cutis, this is kind of the worst picture that I could find on the web just to demonstrate what potentially can happen. I've never seen a case this severe, so I don't want you all to be worried that this is going to happen to you. This is a very, very severe and probably very rare case. This is an x-ray of the lower extremities. You can see here the thigh bones on each side, and all of this white material in the skin and muscle are the calcium deposits that should not be there. This is what we more commonly see in our clinics at Northwestern, would be just these small little areas where there's some calcium deposits, and these generally erode through the skin. They can be painful. Patients will note a chalky-like substance being extruded from their skin, and when unfortunately, they're very tempting to pick, so patients pick at them to try to get the calcium to come out more quickly, and oftentimes they can become infected. So we generally don't recommend a lot of treatment for the Calcinosis cutis. These deposits generally tend to go away on their own, and the important thing is just to to treat the pain and to treat infection if it does occur. Raynaud phenomena, here's again these typical color changes. Blue indicates that there's diminished blood flow or diminished flow of oxygenated blood to the fingertips. The white is what's really reported by patients to be very painful. I refer to it as a kind of a heart attack of the fingers, where there's absolutely no blood flow going through to the tip of the fingers, and patients will come in holding their hands by their sides, trying to get gravity to pull the blood into the fingertips. So this is the more painful part of Raynaud's. And then you can have the what we call the hyperemic phase, where there's lots of blood flowing back into the fingertips after the attack resolves. And this can also be very painful, where the blood's flowing back in. There's been a lot of inflammatory proteins released into the tissue, and so this can be quite painful as well. So that's the R. Now the E is esophageal dysfunction. And you might have been told that you have gastroesophageal disease or esophageal dysmotility. That's evidenced by patients reporting heartburn or chronic cough, sometimes voice changes or a sore throat, difficulty swallowing. These are the symptoms of esophageal disease and scleroderma. And so just merely the absence of heartburn does not necessarily mean that there isn't esophageal involvement. Sometimes we'll see evidence of a dilated esophagus or a patulous esophagus on a chest x-ray, and this patient may or may not have had symptoms. There are not a lot of nerve endings in the esophagus, so sometimes this patulous esophagus is completely asymptomatic and goes undiagnosed. This is a picture from an endoscopy performed at Northwestern, where there's actually an erosion of the esophagus, and you can see where all this tissue is, this red, dark tissue. That's where the normal epithelium, the normal surface tissue, has been eroded away from chronic reflux. So again, you can imagine if your esophagus, which is normally closed, a tube that's not open, and suddenly you have an open tube and you lie down at night after eating a large meal, you can imagine that a lot of the food from your stomach is going to reflux back up into this area here, and that over time is going to lead to erosions in the esophagus. Unfortunately, even with these erosions present, there's a long period before this turns into cancer. So the time between an esophageal erosion appearing and the development of esophageal cancer is upwards of 10 years. So it gives us plenty of time to diagnose this and treat it effectively with medications. But again, I just wanted to draw everyone's attention to that. I often have patients in clinic telling me, well, I don't have heartburn, and I don't think I need to be treated for esophageal reflux disease. And we're pretty firm in insisting that patients do take proton pump inhibitors just to prevent these from occurring, even in the absence of symptoms, for the reasons that I mentioned. So the S of CREST is Sclerodactyly, and that really just means tight skin on the fingers. Dactyly is the, I think, Greek word for finger, and scleros means hard. So this is literally hard fingers. And you can see here, hopefully, that the skin is very tight, it's shiny, the patient's fingers are bent. This patient cannot straighten her fingers all the way because the skin is so tight. So that's that's the S of CREST. And then the T, as I showed before, are these telangiectasias that commonly occur on the face, on the palms, on the chest. You can see here there's some on the neck and the chest area. They can also occur inside the mouth, on the roof of the mouth, or inside the lips. So we'll look there. in patients when we're trying to make a diagnosis of systemic sclerosis and see if we see any of these telangiectasias. So they blanch when you press on them. If you were to press on this lesion here, it would turn white, and then as the blood, when the blood flows back into the capillary, the lesion turns red. So they blanch. So if you're wondering if any of you have these on your hands or your chest, they should turn white when you press on them. So that's the limited subset of the disease. CREST is a helpful mnemonic to kind of remember a lot of the symptoms that occur in the limited form of systemic sclerosis. Now we're going to talk about the diffuse form. Again, these patients can have tight skin, Sclerodactyly. They're more at risk for having fibrosis in the lung. So this is a CAT scan of the lung. You can see here are the ribs. This is the lung tissue here, and this is the heart. And this is the spinal column. So the air inside the lungs should be black like the air outside of the body, and you can appreciate that the inside of the lungs does not look black. It looks more hazy. There are several nodules here, and there's obvious areas of fibrosis. So here you can see there's lots of white, and that's evidence that there's too much collagen in the lung and scar tissue in the lung. And these patients, especially patients of color, will oftentimes have what we call salt and pepper skin, where they lose pigment in addition to becoming darker in some areas. So you can see this patient's neck is very dark, areas on her face are very dark, but there's also areas where she's lost pigment. And so that's evidence of bad skin disease, bad fibrosis. So on histology, when we look at a biopsy that we take in clinic, if we were to look at a normal biopsy from a healthy patient, you'd see here's the outside of the skin, which you can scrape off if you take your nail and scrape your skin. That's the keratinized layer. Then there's the epithelium here, and then this is all the dermis, all down here. And you can see there's a hair follicle, there's nerve endings, there's sweat glands. There's two layers of the dermis, this outside portion and then this inside portion. There's lots of different parts of a normal dermis. This is a schematic of normal skin. This is a skin biopsy from a patient with diffuse disease that I performed in clinic, and you can see here they have that keratinized layer out here, and they have the epidermis here that's in purple. But then instead of having all the normal structures in skin, they just have a ton of this pink, which is collagen, and that's not normal, and that's what makes the skin so tight and makes patients more pigmented. The melanocytes spill their melanin, so patients can get more pigmented. Patients may stop shaving. They don't need to shave anymore. That's because there's no normal healthy hair follicles. It's just basically collagen. So patients may stop sweating. They may stop needing to shave. That's because there's none of the normal parts of the skin there. So treatment overview, that's what I was really asked to focus on today. So we'll spend the last 25 or 30 minutes talking about treatment. So Raynaud phenomena, because it's so common and it's such a big problem for patients, I thought we should spend time focused on that, as well as the lung disease, which is the leading cause of death in patients with systemic sclerosis. So we'll talk about the two different types and the treatments for those. And then the gastrointestinal disease, which is a huge problem in patients with systemic sclerosis and is composed of that gastroesophageal reflux disease, the gastroparesis, intestinal bacterial overgrowth, and rectal incontinence, and that's only a few. There's other manifestations of gastrointestinal disease in SSC that I won't talk about. So we'll start with Raynaud phenomena. So as you know, it's this reversible spasm of the arteries and the digits, and it commonly affects the toes and the fingers, but it can also affect other small blood vessels like the ears and the nipples, tip of the tongue, etc. It's precipitated by cold. A few patients tell me that emotional stress seems to bring it on, but it's mostly the cold, at least in Chicago. And it's accompanied by changes in the temperature of the skin. So the fingers here will feel very cold, and here they may feel cold as well, and then here they may feel warm because there's increased blood flow there. So the occurrence of Raynaud's, there may be people tuned in today who have a diagnosis of Raynaud's and maybe have some reflux and are worried that they have systemic sclerosis. So I wanted to include this slide to encourage you that in most cases, if you have Raynaud phenomena, you do not have systemic sclerosis. The proportion of patients with Raynaud phenomena and systemic sclerosis is very small in comparison to all of the patients in the U.S. or in the world that have Raynaud phenomena. It's very common. 10 to 30% of the healthy population has what's called primary Raynaud phenomena that's not associated with any connective tissue disease or any collagen vascular disease. It's more common in women, and most people with Raynaud's do not have and will not develop scleroderma. But 95% of patients with scleroderma report Raynaud phenomena. So when we see a patient in clinic and they tell us and we probe them and they still insist that their fingers do not change color in response to cold, that's a reason that we would question our diagnosis and really try to be very careful before we gave the patient a diagnosis of systemic sclerosis. So what do the vessels look like in a patient with Raynaud phenomena under the microscope? So here's a photomicrograph of digital vessels from a normal, healthy person. So here you can see in red, this is the smooth muscle layer of the digital artery, and there's plenty of room here for the blood to pass. This is an artery, which has a very muscular wall, and this is a vein, which has a less muscle in the wall, but again, lots of room for the blood to circulate. In a patient with scleroderma, there's a proliferation of the cells of this smooth muscle layer. So it's referred to as onion skinning. It can almost look like an onion cut down the center where there's all these different layers of just proliferating cells that should not be there. And you can see that the lumen, the area for the blood to flow, is virtually absent in this blood vessel. And that's why you have the diminished blood flow in the Raynaud patients having Raynaud phenomena. Here's a photomicrograph of a vessel, and I included this because there's a lot of inflammation, at least early in the disease, and you can see all of these dark bean-shaped cells in the vessel wall that should not be there. So this is all these dark bean-shaped cells are inflammatory cells, and they're responsible for causing this proliferation of the smooth muscle layer. So when left untreated, the lack of blood flow can lead to digital ulcers. And these, for those who have not had them, are very painful, and they can take a very long time to go away. So we try very, very hard, as do other doctors at other scleroderma centers, to prevent an ulcer from forming, because once an ulcer is there, it's very difficult to get it to go away. So there are many therapies to treat Raynaud phenomena. I just kind of included a laundry list here. Most of these things are drugs to make the smooth muscle and the blood inside the blood vessels relax. Those are called vasodilators. So we try to dilate the blood vessels. But things like moisturizers to keep the skin soft, these are just some that I have found to be helpful. This Norwegian hand formula. I have a patient who insists on using olive oil, or he finds that it soaks into his skin very well and isn't quite as greasy as some of these moisturizers like the Neutrogena one or Eucerin. Taking just a vitamin E tablet a day, it's never been actually studied and shown to be effective, but it makes sense just from the medical standpoint that vitamin E is believed to help with vascular health. So we'll go ahead and tell patients to start taking a multivitamin or take some vitamin E tablets. A baby aspirin decreases the clotting of blood, so we'll tell patients to start a baby aspirin. And then all of these things are these vasodilators here. Digital sympathectomy is a surgical treatment where a hand surgeon would go in and actually remove the nerves that cause the blood vessels to constrict or to clamp down, and then Botox injections. So you've probably heard of these being used in the face for wrinkles and fine lines, but we actually have had some success using Botox injections into the bases of the fingers to, again, try to prevent these nerves from spasming and causing the blood vessels in the fingers to clamp down. So the approach that we use at Northwestern involves more than just vasodilators. Obviously, it's very important to keep warm and to avoid cold and really keep the core warm. So it's not just the fingers or the toes, but really, wearing a sweater, wearing long underwear to keep your core warm. Studies have shown that it's the core getting cold that really triggers the Raynaud as much as it is holding a cold glass, for instance. You want to avoid anything that's a vasoconstrictor. So anything that's going to make the blood vessels get tighter, and those things include any kind of amphetamine. So if anybody's taking Adderall for attention deficit disorder, that's something. I have a few patients that need to be on that, but we try to limit the dosage of the Adderall. Same thing with Provigil. These can help attention deficit disorder, but they also are stimulants, and so they make the Raynaud's worse. Same thing with Ritalin. Some patients have bad migraine headaches, and ergotamines are very successful in controlling and preventing the headaches, but these are vasoconstrictors, so you need to be careful. And then there's medicines that are commonly prescribed for menopause, like clonidine, which also causes blood vessels to clamp down. And then more commonly used drugs like caffeine, which we all ingest, or nicotine, which we hope that you're not ingesting through cigarette smoke. But these are vasoconstrictors as well. So I always chuckle to myself when I have typically a young college student come in drinking Red Bull, which has ungodly amounts of caffeine in it, and and she's worried about Raynaud's. And usually, if just not drinking so much caffeine through Starbucks or not drinking so much Red Bull usually does the trick. We don't need to treat that patient. Of course, reducing stress and controlling pain. So pain, when you're in pain, your blood vessels constrict. And that's physiologic. Back in the day when women used to have babies out in the field, the pain of childbirth was helpful because it actually helped the blood vessels of the uterus clamp down after birth, and so it would help prevent women from hemorrhaging to death. So pain is a strong, strong motivator for vasoconstriction, and so it's very important if you're having pain that you mention it to your doctor and come up with some kind of system to control pain, whether it's opioid analgesics or NSAIDs or Tylenol or fentanyl patches. We've used all of these treatments in our patients and get that pain under control. Ginkgo biloba has been shown to be effective in primary Raynaud's, but it has never been shown to be helpful in patients with scleroderma. So I just include that because patients sometimes ask about that. So it's more than vasodilators. Again, it's important to keep your finger protected. If you start to notice a digital ulcer, you want to place a Band-Aid or some gauze or something to protect the area. It's a good idea to see an occupational therapist. If you're prone to ulcers, they can design special neoprene sleeves that can be worn. They can also soak patients' hands in paraffin baths, which is makes patients feel a lot better. And acupuncture, I include, there's no data to support its use, but if it helps you, acupuncture or massage therapy with controlling the stress in your life, I don't see a reason to avoid it. So our approach, as probably most scleroderma centers in the country, is to first counsel patients about lifestyle modifications. So that includes, avoiding cold, always making sure you have a sweater with you, etc. Maybe starting a low-dose aspirin if you don't have a history of bleeding. Starting the vitamin E tablet and protecting your skin if it gets dry. And then the first line of treatment is with, and I apologize for the terminology, the medicalese here, angiotensin receptor blockers, also called ARBs. And these are things like losartan, It's the most commonly used one. And then calcium channel blockers, which, nifedipine is a commonly used one, or amlodipine. You don't need to remember these names. Just suffice it to say that the calcium channel blockers and the angiotensin receptor blockers are first line, and that's pretty much what everybody's using. And then if you don't respond to one or the other, oftentimes the physician will add on the other one. So if you start with a calcium channel blocker and you're still having Raynaud's, we might add on an angiotensin receptor blocker. And then if you're still having Raynaud's, we might go to some of these other therapies. Sympathectomy, I put that in blue. I don't tend to refer patients to a hand surgeon for Raynaud's. It's oftentimes just not needed. But there's lots of treatments for Raynaud's, so you should talk to your doctor. If you're having Raynaud's, we just need to be aggressive about getting it under control. So lung disease and SSC, again, there's the two types. The interstitial lung disease, which is mostly fibrotic or scar tissue, and the pulmonary arterial hypertension, which is, again, the high blood pressure within the lung vessels. So interstitial lung disease, we'll start with that first. It's symptomatic in about 40% of patients. But it can be present in 80 to 90% of patients, but be completely asymptomatic. So patients may have interstitial lung disease, which is the fibrosis in the lungs, and not be having any trouble breathing or fatigue or cough. So that's why we do screen with pulmonary function tests as well as CAT scans of the lungs to diagnose it. We want to know if it's there. Usually occurs early, within the first 3 to 5 years in the disease from the onset of the disease. So if you're 20 years out and you haven't developed, or 10 years out and you haven't developed any interstitial lung disease, it's very unlikely that you ever will. But if you do develop interstitial lung disease secondary to scleroderma, it is definitely treatable. So here's, again, under the microscope, this is a normal healthy lung, and you can see the nice lacy pattern. And this is a patient with scleroderma with lung disease. So you can see there's lots of this collagen, similar to the dark pink in the skin. You can have the dark pink collagen that appears in the lung, and it disrupts the normal architecture. It interferes with the blood flow, obviously, through the lung, and the exchange between the gas, which would be in the air sac here called the alveoli. The gas that you breathe in, the oxygen that you breathe in the air, should be able to travel across this membrane into the blood vessel. And when there's all this collagen here, it can be difficult for that to occur. So we diagnose interstitial lung disease by talking to and examining the patient. We do a careful lung exam. We ask about pulmonary symptoms like shortness of breath and cough. We'll refer patients for pulmonary function tests, and we do these longitudinally, usually every 6 months or so initially, and then less frequently as the disease progresses. We'll order sometimes a 6-minute walk test to record the distance that a patient can walk in 6 minutes. We'll check a high-resolution CAT scan of the lungs to look for the fibrosis, and virtually never ever have to do a lung biopsy. That's seldom indicated. So the pulmonary function tests, for those of you who haven't done them, there's 3 components. Spirometry is the first one, and here's a picture of a patient doing the spirometry portion of the test. And here, this is what we record. So this is normal breathing. You're breathing in, you're breathing out, you're breathing in, you're breathing out. And then the respiratory therapist will ask you to take a big, deep breath. So you take a huge breath, and you blow it out as fast as you can. And all these numbers mean something to us. And here's how we get the lung volumes in a plethysmograph. So this is also called a body box, but we'll record numbers that help us know if you have lung disease. So this is what we're measuring. The last portion of the pulmonary function test is called the DLCO. That's also measured in the body box. And that's basically a measurement of the amount of healthy blood vessels in the lungs. So here's an airway, and you can see the air will travel through here, and it'll go into these air sacs called alveoli, and then the oxygen should flow into the arteries here, into the arteries here, which after they're oxygenated, they'll turn red. So this is a schematic demonstrating that the air will be in the air sacs, and if there's no barrier to normal transit, the carbon monoxide or oxygen will flow across the membrane and into the red blood cell. if there's destruction of the lung tissue, the migration of the oxygen from the air sac into a red blood cell will be affected and diminished. So we keep track of that number. It helps us know if the patient's lungs are getting better or getting worse. This is a picture of a CT scanner, and so the patient will lay on this on their back, and pictures will be taken throughout the lungs every millimeter and a half, so that we can see exactly what's going on inside the lungs. Here's a picture of a normal CT of the chest. Again, this is the spinal column. And these are the lungs here, so this is normal. You can see that the outside of the body, where the air is the same as the inside of the lungs. That's normal. Now in a patient with mild interstitial lung disease, you can see some evidence of fibrosis or inflammation, also referred to as ground glass. And if it progresses, you can see that there's more damage here. This is called honeycombing, and that's a little bit more extensive. And then here's a picture of a patient with severe lung disease. Now this patient will definitely be symptomatic and will have trouble breathing for sure. You can see all the diseased lung here on both sides. So is interstitial lung disease always progressive? No, it is not. Again, we see it in upwards of 80% of patients. Again, the rapid progression usually occurs within the first 3 to 5 years of disease. That's when you're at the highest risk for getting lung disease. Patients with an anti-topoisomerase antibody in their bloodstream are more likely to progress to having lung disease, but that's definitely not always the case. But many patients will develop a little bit of lung disease. It will be stable. It won't need aggressive treatment. Sometimes it even gets slightly better on its own over time. So it's important to speak with your doctor about whether or not aggressive treatment is warranted. Sometimes a watchful waiting approach is best, at least for a few months, to see which way you're going. Is your lung disease progressing, or is it kind of stable and getting better? Treatments for interstitial lung disease include oxygen, drugs, medications like cyclophosphamide or Cytoxan, which can be taken in the pill form or intravenously, mycophenolate mofetil, which is also called Cellcept. That's an oral medication. These medicines were the subject for the Scleroderma lung study 2, which just completed enrollment, and now they're analyzing the data. Pulmonary rehabilitation can be helpful. Stem cell transplant can be helpful in patients. There's some good data coming out that stem cell transplant may improve lung disease in very specific patients that are carefully screened to undergo the procedure, because there is a risk of infection and or death after a stem cell transplant. So it's nothing to enter into lightly, but it can be quite effective in some patients. And rather than go through the laundry list of medicines used to treat interstitial lung disease, I thought it best to just show you that there's a website called clinicaltrials.gov where you can just Google that and you can see the studies that are ongoing. So here there's one that's looking at medicine called tadalafil in interstitial lung disease for scleroderma patients. So that's a useful website to check what treatments are being tried and if there's a center near you where you can enroll in a study. Pulmonary arterial hypertension is the other form of lung disease that patients with systemic sclerosis can get. Here's a picture of the abnormal pulmonary artery under the microscope. Again, you can see that onion skinning very clearly here with the small area where the blood can pass through. And this is a schematic. So again, usually the right side of the heart is much smaller than the left side. You can see the muscle on the left side is much thicker than the muscle on the right side of the heart. And that's because in normal circumstances, the right side of the heart only has to pump blood into the lungs, and the left side of the heart is responsible for pumping blood to the entire body, out the aorta, down into the legs and your arms and your brain. So the left side has to be much stronger than the right side. In a patient with pulmonary arterial hypertension or high blood pressure within the lungs, the right side has to get bigger. It has to hypertrophy or enlarge in order to be able to pump against the resistance that's in the blood vessels in the lungs. So you can see here, again, like that echo I showed in the beginning of the talk, where the right side is much bigger than the left side, and that's very abnormal. So there's many treatments for pulmonary arterial hypertension. I've listed them here along with the date that they were approved by the FDA for treatment of pulmonary arterial hypertension. These medicines should be given by a doctor who is very familiar with giving them and prescribing them and with the complications that can arise from their use. So there are many centers of excellence in the treatment of pulmonary arterial hypertension, and if you've been diagnosed with pulmonary arterial hypertension, you should definitely seek out a center of excellence where they can choose the appropriate medicine for you and or combination of medicines for you. So we'll talk about gastrointestinal disease just for the last few minutes. Again, here's the Patulous esophagus that I mentioned earlier. Treatments for gastroesophageal reflux include avoiding calcium channel blockers for Raynaud's if you can, because calcium channel blockers can make GERD worse. Avoiding large pills that may get stuck, and then all these lifestyle modifications, so avoiding late, large meals, fatty meals. You want to exercise to maintain an ideal body weight, and then also very importantly to elevate the head of your bed so that you're not breathing in your stomach contents at nighttime when you're asleep. Treatments include antacids, which are usually not very effective. Histamine receptor blockers, again, the insurance companies love for us to use these because they're cheaper. But really what works and has been shown and studied to work are proton pump inhibitors. And some of these can be bought over the counter, like Prilosec and Prevacid and Zegerid. And they work just as well as the ones that you need a prescription for, like Nexium and Acifex. So try these first if you can. And if they work, then great. Gastroparesis is another manifestation of gastrointestinal disease in scleroderma. Again, the same lifestyle modifications apply to patients with gastroparesis as similar to gastroesophageal reflux disease, with the addition of perhaps avoiding fibrous fruits and vegetables that may more easily get stuck and not flow through the intestines as well. Ingesting soups and smoothies and pureed foods are often the best, and you want to drink plenty of water throughout each meal so that food does not get lodged in your esophagus or in your intestines. And then medications to promote motility of the intestines can be helpful. So metoclopramide, erythromycin is an antibiotic, but it can help. And then in more severe cases, you can use an electric nerve stimulator that stimulates the nerves of the gut to promote motility. You have to be careful with these anti-nausea, anti-vomiting medicines, as some can make the transit slower. For small bacterial overgrowth, which is just basically too much bacteria in the gut, because of the delayed motility through the gut, sometimes there'll be an overgrowth of the bacteria, and that can be treated with antibiotics. There's lots of antibiotics that are good. You want to avoid antidiarrheals because they slow transit and they slow the emptying of the intestinal contents. So you want to get all that bacteria out of you, even if it comes out in the form of diarrhea. You want to clean out your gut. So you want to avoid antidiarrheals. And then there is some role for some probiotics. So rectal incontinence is a big problem. We've started asking patients about it because it's obviously not something that patients like to bring up. I was surprised when I read the statistics that say that rectal incontinence is very common and is present in 40 to 70% of SSC patients, and that was a study that was done in Europe. So it's very common, and it's a common late complication in the disease. Here's just a diagram of the anatomy. So you have the internal, this is the colon here coming down. This is the rectum, where the stool is stored until you're ready to have a bowel movement. And then this is the internal anal sphincter here on each side. That's under involuntary control. So when the rectum is full of stool, the stool will press on the internal anal sphincter and you'll get the sense that you need to go to the bathroom, and you'll be able to hold your stool in your rectum until you get to a toilet, and that is the external anal sphincter here that you can kind of clamp down until you're at a toilet and you can relax, and then you can have a normal bowel movement. In patients with scleroderma, this internal anal sphincter, the sensory of this, the sensory supply to this muscle is thought to be impaired, and the walls of the rectum are not getting the signal that the rectum is full with stool. And so that's thought to be a major reason why patients with systemic sclerosis get rectal incontinence, is that you're just not aware when you have lots of stool in your rectum that needs to come out. So there's decreased tone of the internal anal sphincter muscle. It's not a toned muscle, and there's nothing you can really do to build it up by doing exercises, but you can work with doctors who specialize in rectal incontinence to try to help the musculature be more normal and sense when the rectum is full. So let's see, we'll talk about the treatments now. So behavioral, I've talked to one of our gastroenterologists who works with my patients, and he has some success with having patients try to have a bowel movement at a specific time each day. So for instance, patients will wake up, have a caffeinated beverage that speeds intestinal motility, maybe exercise rigorously, and then try to have a bowel movement, a good bowel movement before going to work, for instance. Seeing a dietitian is a good idea to help avoid foods that are known to make rectal incontinence worse, like cured meats, so a lot of lunch meats you might want to avoid, and a lot of fatty foods, lots of dairy, and then the citrus fruits. If you have bowel impaction, so if there's too much stool in your bowel, you'd want to get rid of that, and a doctor could help you do that, just to get all the stool out once and for all initially, and then try to maintain a more healthy bowel regimen. You can take bulking agents that can be ingested or injected. So the bulking agents can help the stool be more bulky, so that you will feel, if the stool is more bulky, it'll hopefully help you sense when the rectum is full. And then they can inject these bulking agents here under ultrasound guidance next to the rectum. In some cases, that will help you, again, know that your rectum is full of stool and you need to have a bowel movement. So those can be injected under ultrasound guidance. Antidiarrheals obviously can help, but you need to be careful with that because you don't want to cause bacterial overgrowth. There's other medicines that can be tried, tricyclic antidepressants, something called hyoscyamine, and then biofeedback to train the anal muscles can be used, and we've had good response in patients that have been referred to an experienced technician who's used to working with patients with rectal incontinence. And then kind of as a last resort, a sacral nerve stimulator to again try to give back those normal neuronal signals to the muscle of the internal and external anal sphincters. So I hope I've impressed upon all of you that systemic sclerosis, albeit a very systemic disease and involving many different organs in the body, is treatable, and I think it's important to team up with a doctor that you get along with and that you have a good relationship with, and just be very honest with your symptoms and work to get them under control. There is an improved 5-year survival. The survival keeps getting better and better in patients with systemic sclerosis. New treatments are being tried every day, and there's no reason why you should be seeing a doctor who doesn't treat you and doesn't treat your symptoms. There's many, many treatments to try, and it's important to be seen at a center where doctors have experience trying all the different medicines. And that's the end of my presentation. I hope it was helpful, and I'd be happy to answer questions.
Monique, that's great. A number of questions have come up, and I'll try to synthesize a couple together just so we can use the time efficiently. And if it's okay with you, maybe we'll just go over just a few minutes because we have a number of questions. And
of course, yeah. I'm sorry I spoke too long.
Not at all. So one of the things that's come up a little bit is on sort of some of the heartburn type questions. I wonder if you could clarify about sort of acid reflux versus non-acid reflux on the one hand, And then sort of just more broadly, once patients start to take medications that raise the pH, should they be concerned about the kinds of foods they're intaking, and then as a sequelae to that, sort of vitamin supplements, or which I guess relates to nutritional absorption type of issues?
So those are all good questions. There is concern, and that's been raised in the lay press about, taking these proton pump inhibitors long term. You're basically, raising the pH, as you said, of within the stomach, and there's concern that you might be predisposing patients to more infections in the stomach, like with H. pylori or something like that, because there isn't the acidity to kill them, and B, you may be affecting the patient's ability to absorb calcium, for instance, which requires an acidic environment for maximum absorption. And those are very legitimate concerns. What I tell my patients is to try to take their calcium supplements at a different time of the day, and regularly, in lots of small doses throughout the day, rather than just relying on a big tablet, which is seldom absorbed very well, at the same time they're taking their proton pump inhibitor. So if you're taking your proton pump inhibitor 30 minutes prior to meals, which is the way that you should be taking it, you don't want to take the calcium tablet with your meal. You want to space it out and take it at a different time of the day. And there's lots of good ways of getting calcium too. I mean, dietary is probably the best, but there's Viactive chews. Tums are a great source of calcium. The pills, the big horse pills of calcium, are hard to absorb and difficult to digest. So we tell patients to take calcium citrate rather than calcium carbonate, which is harder to absorb, and again, take it at different points throughout the day. So it is a concern with the nutritional deficiencies and perhaps increasing the risk for infections. I can tell you we haven't observed that in our patients taking even proton pump inhibitors twice a day. We have not observed an increased risk of stomach infections. So it doesn't seem to be a very common complication. In terms of the reflux, the acid reflux, I wasn't quite sure I understood the question.
I think it just relates to this, the sort of the issue about non-acid reflux. Obviously, what the proton pump inhibitors and the H2 blockers, on top of the PPIs can do for you is obviously raise the pH, but they don't actually prevent the reflux itself. They just raise it. So it's less painful, or it's potentially less damaging, but maybe there's still, at least in the literature, some discussion about quote-unquote non-acid reflux, whether or not that can still lead to long-term damage, particularly if you're aspirating some of your stomach contents.
Exactly. So I think the proton pump inhibitors are very effective in raising the pH of your stomach contents, so that when food and when you're the ground up food in your stomach refluxes, which it will if you have an open esophagus, it's going to reflux, that it's not as caustic and not as damaging to the epithelium of the esophagus, that inside layer of the esophagus. So that's why it's so important to elevate the head of your bed. And I see a few of my patients that have logged on, and they'll know that I preach about this a lot. It's really important to make sure your head is elevated when you sleep. So either with a wedge pillow, or actually sticking a block underneath the head of your bed, under the legs of the bed, so that the non-acid reflux will be less of a problem. Because if you have a patulous esophagus, there will be reflux when you're lying flat, and that's definitely a big risk factor for for worsening interstitial lung disease. So, breathing in your stomach contents into your lungs is obviously not something that we would want to have happening. And so to elevate the head of the bed is probably just as important as taking the proton pump inhibitors.
Right. Just maybe one more sort of concomitant medication type of question as it relates to reflux. I have heard a number of physicians speak about calcium channel blockers as a potential solution for some of the, in particular, Raynauds. But I've also read that the calcium channel blockers can basically induce additional reflux, at least in scleroderma patients. Have you found that to be a problem, and do you then tend to recommend ARBs instead of CCBs, or what has been your experience, with how to handle some of that overlap?
So great question. So yeah, the calcium channel blockers, that's a known side effect of them, is relaxing the lower esophageal sphincter, the muscle at the base of the esophagus. So if we want patients to have relaxed blood vessels and relaxed smooth muscle. So calcium channel blockers work great for Raynaud's, but they also have the risk of causing worse reflux, worse gastroesophageal reflux symptoms, and a lot of edema. A lot of lower extremity edema is another huge problem with the calcium channel blockers. And for those reasons, we do start patients on an ARB, an angiotensin receptor blocker, like losartan, as first line. And then if that doesn't do the trick, then we'll add maybe a very low dose of a calcium channel blocker on, and question the patient very carefully each time they come. Are you having more reflux? And if they are, then maybe lowering the dose of the calcium channel blocker and adding on one of those myriad drugs that I listed below. So sometimes it takes 3-4 medications to control the Raynaud's, because we can't increase the calcium channel blocker dose as high as we might like to because of the worsening reflux symptoms. So it's a big problem. Calcium channel blockers are great for Raynaud's, but they're the enemy of the patient with bad GERD.
Right. Let me switch gears. A number of our listeners today were inquiring about pain. So let me just try and frame it a little bit. So it sounds like that we've got different sources of pain, whether it's digital ulcers and or calcinosis, or maybe just from the Raynaud's itself. How do you recommend patients deal with the pain? And I guess maybe as a maybe you might want to put it in the context, certainly some of the pain medications might basically overlap or amplify some of the other issues that some patients report with fatigue, lack of sort of energy and sort of vitality. So do you want to sort of talk a little about how you think about pain, maybe particularly in the context of fatigue or some of those complications?
Yeah, I mean that's probably an hour talk in itself. Pain is so complex to manage, and I guess if you have a pain center close to where you're living that you could go to and see a physician who specializes in pain, that might be the best approach. I oftentimes refer patients to pain centers for help managing the pain, because when you use opioid analgesics like Vicodin or Percocet, things like that, those can constipate patients. And if you have a patient with delayed intestinal motility to begin with, and then you put them on an opioid, their pain may be controlled, but then you've given them terrible bloating and gas pain. So again, I think it's like Raynaud's, where you have to sometimes use a low dose of a lot of different medicines. Centrally active pain medications like antidepressants we often use, like Cymbalta or amitriptyline. Gabapentin is a medicine that helps stabilize nerve membranes, so we'll oftentimes use that for patients with more nerve pain from the calcinosis or from the Raynaud's. Opioids are certainly, can be used with caution. I have a few patients on a fentanyl patch, so they'll actually put a patch on their skin that they change every 72 hours. That gives a little bit of an opioid, throughout the day and night, so that they're not having that on-off effect with the pills that sometimes with opioids you take the pill, you feel good for 2 hours, and then as the pill starts to wear off, the pain starts to return. So the patch can be a good approach if you just want a continuous dose of opioid analgesic. But I would say, again, just maybe having a low dose of several different medicines can be helpful, as opposed to taking a large dose of one. So, the centrally active pain medications, the antidepressants, the Neurontin, the opioids, Tylenol, NSAIDs, are probably the things that we most commonly use. with varied success. But whatever it takes, you really need to control the pain, because if you're having a bad digital ulcer and you're in excruciating pain, it's going to be very difficult to get that ulcer to go away.
Right. Okay, I'm going to basically ask one more question, then I think we are going to have to wrap up, and that has to do maybe with renal disease. You didn't really mention much about it today, but I thought maybe if you want to just put that in the context for patients, there's one or two questions about renal disease and what patients ought to be watching out for and what therapies might be available. So maybe we can end on that note.
Yeah, so I think I just had one brief mention of that the kidneys can be involved in scleroderma in an early slide, and you're right, I didn't focus on it. It's very important to focus on. So the kidneys are thankfully not very commonly involved in a serious manner in scleroderma. Mild elevations of blood creatinine can be seen in many patients with scleroderma, but it's usually not serious. But there is one phenomena called scleroderma renal crisis, where there's a very marked elevation in the creatinine, a very marked elevation in the patient's blood pressure, and the increased blood pressure can damage the kidneys, sometimes irreversibly. So we tell all of our patients with the diffuse form of the disease to be monitoring their blood pressure, not 5 times a day, but once or twice a week at the same time each day. Monitoring the blood pressure, making sure that it's staying stable for them, and then being very diligent about calling your physician or going to an emergency room if you notice increases in the blood pressure, substantial increases like 20 points or more consistently, because we've got great treatments for scleroderma renal crisis, ACE inhibitors like captopril or ramipril. There's lots of different ones. If started early, almost invariably save the kidneys and prevent long-term renal damage and the need for dialysis. But if started too late after there's a lot of renal damage, can lead to a patient having to be on dialysis and needing a kidney transplant. So it's very important for especially the diffuse patients. It's very, very uncommon in limited patients to have scleroderma renal crisis. There's a few patients that were reported, but it's much more commonly seen in patients with diffuse disease with a positive RNA polymerase antibody, RNA polymerase 3 antibody, which was one that I didn't mention, but that can also be tested for. And if positive, that's just another risk factor for developing scleroderma renal crisis. So if you have diffuse disease, you have a positive RNA polymerase 3 antibody, you should definitely be checking your blood pressure, a couple times a week and making sure that it stays stable for you. So that's the other thing. If your blood pressure is usually 90 over 60, and it's 90 over 60 every time you check it, and suddenly it's 130 over 80, while that's still a normal blood pressure for most Americans, that's very abnormal for you. You're going from 80, to 130, or 90 to 130. That's a huge increase in your blood pressure. So that's why it's really important for patients to know their blood pressure and be monitoring their own blood pressure, because nobody in the medical profession is going to really bat an eye if you have a blood pressure of 130 over 80, because that's still within the range of normal. But if your normal blood pressure, and you know that your normal blood pressure is usually 90 over 60, then that's very elevated for you, and that warrants emergent treatment.
Great. Monique, thanks so much. We're out of time now, so we're over time, but I really appreciate you staying on board to go through a number of questions for us. Just to all the folks who are still on board, when you close the webinar window, you can provide some really critical feedback for us just by completing the short survey. Also, I'd like to just emphasize once again that we do depend on the community's support to continue our investment in the most promising research, as well as our ability to bring these kinds of information sessions to you. Please visit us online at sclerodermaresearch.org or call our offices directly at 1-800-441-CURE. C-U-R-E. Thanks again for sharing time with us today. Our next webinar will feature Dr. Lorinda Chung of the Stanford University Scleroderma Center. That webinar will take place on Friday, July 12th at 10:30 a.m. Pacific Time. Goodbye for now.